Right now, as you're watching this video, there's a 30-foot long muscular tube inside your body performing one of the most complex chemical processes on Earth. And if you're a nursing student, you need to understand every inch of it. Because here's what your textbook won't tell you. Digestive system disorders are behind 70% of hospital admissions, and the nurse who truly understands the system becomes the one who catches problems before they become emergencies. Hey everyone, welcome back to NurseBrain. I am Neil Brian Galve, and if you're here, you're probably either cramming for an A&P exam, preparing for NCLEX, or trying to understand why your patient's bowel sounds matter more than you think. Here's the reality. Most nursing students memorize the digestive system just long enough to pass their exam, then forget it. But here's what I learned after years of clinical practice. The digestive system isn't just about food going in and waste coming out. It's your body's chemical factory, immune system headquarters, and the key to understanding everything from medication absorption to post-op complications. So, in this video, I'm going to take you on an ultimate journey through the digestive system. We'll follow food from the moment it hits your lips to the moment it, well, you know. But more importantly, I'll show you the clinical connections that will make you a better nurse and help you absolutely crush your exams. By the end of this video, you'll understand not just the anatomy and physiology, but why your post-surgical patient isn't eating and why that medication isn't working, and how to assess bowel sounds like a pro. Let's start our journey at the very beginning, the mouth. And right away, I want to blow your mind with something most people don't realize. Digestion starts before you even take a bite. Ever smell fresh bread baking and start salivating? That's your parasympathetic nervous system preparing your digestive tract. Your salivary glands are already producing up to 1.5 liters of saliva per day. That's like 3 water bottles worth. But here's the clinical connection that matters. Saliva isn't just spit. It contains salivary amylase, which starts breaking down starches immediately. This is why patients with a dry mouth from medications or dehydration have trouble with digestion from the very start. Now, let's talk teeth. You have 32 of them for a reason. Incisors for cutting, canines for tearing, and molars for grinding. But here's what's crucial for nursing. Poor dental health directly impacts nutrition and medication absorption. That elderly patient who's not eating, check their mouth first. The tongue isn't just for taste. It's a powerful muscle that forms the bolus and initiates swallowing. And those taste buds, they're not just for enjoyment. They trigger digestive enzyme release through your entire GI tract. Once that bolus is formed, it's time for one of the most coordinated muscular actions in your body, swallowing. This involves 26 muscles working in perfect sequence, and here's why this matters clinically. Stroke patients often have dysphagia because this coordination is disrupted. The pharynx is like a busy intersection. Food, air, and liquids all pass through here. That little flap called the epiglottitis, it's literally the difference between food going to your stomach and going to your lungs. Aspiration pneumonia? Anyone? Now, we enter the esophagus, a 25 centimeter muscular tube that's way more complex than you think. It's not just gravity moving food down. Peristalsis, those coordinated wave-like contractions, can push food to your stomach even if you were hanging upside down. Here's a clinical pearl. The lower esophageal sphincter is supposed to stay closed except during swallowing. When it doesn't work properly, you get GERD. When it won't open properly, you get achalasia. Understanding this physiology helps you understand why your patient needs that PPI or why they can't keep food down. Welcome to the stomach, the most misunderstood organ in the digestive system. Most people think it's just a storage bag, but it's actually a sophisticated chemical laboratory. The stomach has four main regions: the cardiac region, where food enters, and fundus, that expands to accommodate food, the body, where most mixing occurs, and the pyloric region that controls emptying. Each region has a specific job, and understanding this helps you understand why gastric surgeries affect patients so differently. But here's where it gets fascinating. Your stomach produces 2 to 3 liters of gastric juice daily. That's more than a large soda bottle. This juice contains hydrochloric acid so strong it could dissolve metal, pepsinogen, that becomes the protein digesting enzyme pepsin, and intrinsic factor that's essential for B12 absorption. It's clinical connection time. Ever wonder why patients get B12 deficiency after gastric bypass? It's because they've bypassed the part of the stomach that produces intrinsic factor. No intrinsic factor, no B12 absorption. Hello, pernicious anemia. Those parietal cells producing stomach acid, they're also why we give PPI to ICU patients. Stress ulcers form when the protective mucus barrier breaks down and that acid starts digesting the stomach wall itself. Food stays in the stomach 2 to 4 hours, getting churned into chyme. That soupy mixture that's ready for the small intestine. The pyloric sphincter acts like a bouncer, only letting small particles through. This is why patients with gastroparesis feel full so quickly. Now, we enter the small intestine, and despite its name, this is the giant of the digestive system. At 20 feet long, it's where 90% of digestion and absorption occurs. Miss this section, and you'll never understand malabsorption disorders. The small intestine has three sections: the duodenum, jejunum, and ileum. Each has specific job. The duodenum is where the real chemical breakdown happens. The jejunum absorbs most nutrients, and the ileum absorbs B12 and bile salts. Here's what makes the small intestine so efficient. Villi and microvilli, these finger-like projections increase the surface area to about the size of a tennis court. That's right, you have a tennis court's worth of absorptive surface inside you. But here's the clinical goal. Each villus contains a capillary bed and a lacteal, a lymphatic vessel. Water-soluble nutrients go into the blood and straight to the liver. Fat-soluble vitamins A, D, E, and K go into the lymphatic system. This is why patients with lymphatic disorders can have fat-soluble vitamin deficiencies. The duodenum is where pancreatic juice and bile enter through the hepatopancreatic ampulla. Pancreatic juice neutralizes that acidic chyme and contains enzymes that break down proteins, fats, and carbohydrates. Bile emulsifies fats, making them easier to digest. Clinical pearl. Patients with pancreatitis can't produce these enzymes properly, leading to malabsorption and steatorrhea, those fatty, foul-smelling stools. And patients without a gallbladder, they can store bile, so they have trouble digesting large fatty meals. Finally, we reach the large intestine, 5 feet of colon that's responsible for the final act of digestion. By the time chyme reaches here, most nutrients are absorbed. The colon's job is water absorption and waste elimination. The large intestine starts with a cecum in that little appendix, which isn't useless, by the way. It's actually a reservoir for beneficial bacteria. Then we travel up to the ascending colon, across the transverse colon, down to the descending colon, through the S-shaped sigmoid colon, and finally to the rectum and anal canal. Here's what's fascinating. Your colon is home to trillions of bacteria, your microbiome. These bacteria produce vitamin K, which is essential for blood clotting. This is why patients on long-term antibiotics can develop bleeding disorders. The colon absorbs about 1 to 2 liters of water daily from that liquid chyme, forming solid feces. This process takes 12 to 48 hours. Too fast and you get diarrhea, too slow and you get constipation. Understanding normal bowel patterns help you assess your patients. No bowel sounds could be ileus. Hyperactive bowel sounds may be obstructive or gastroenteritis. High-pitched tingling sounds, definitely think obstruction. Now, let's talk about the organs that don't touch food but are absolutely essential for digestion: the liver, gallbladder, and pancreas. The liver is the ultimate multitasker. It produces bile, metabolizes nutrients, detoxifies substances, and stores vitamins. It processes everything absorbed from the small intestine before it reaches the rest of your body. This is called the first pass effect, and it's why some medications are given sublingually or rectally to bypass liver metabolism. The gallbladder stores and concentrates bile. When you eat fat, cholecystokinin or CCK is released, causing the gallbladder to contract and release bile. No gallbladder, no bile storage, which means difficulty digesting fats. The pancreas has dual roles: endocrine, producing insulin and glucagon, and exocrine, producing digestive enzymes. Pancreatic juice contains bicarbonate and neutralized stomach acid and enzymes to break down all three macronutrients. Let's bring this all together with real clinical applications. Understanding the digestive system helps you understand why certain medications are given with food, why others are given on an empty stomach, and why route of administration matters. Enteral nutrition works because the GI tract is designed to process nutrients, but patients with short gut syndrome or severe malabsorption need parenteral nutrition because their digestive system can do its job. Age-related changes are crucial to understand. Decreased saliva production, reduced gastric acid, slower gastric emptying, decreased intestinal motility, and changes in liver metabolism. This is why elderly patients are more prone to constipation, medication interactions, and nutritional deficiencies. Post-operative patients often have a decreased GI motility due to the anesthesia and pain medications. This is why we assess bowel sounds, encourage early ambulation, and monitor for signs of ileus. Understanding the digestive system also helps you educate patients about medication timing, dietary modifications, and recognizing signs of GI complications. Alright, we've just traveled 30 feet through the most complex chemical processing plant in the known universe: your digestive system. From the moment food hits your mouth to the final elimination, every step is precisely coordinated and clinically relevant. Remember the key takeaways. The mouth starts digestion with enzymes and mechanical breakdown. The stomach is a chemical laboratory producing acid and enzymes. The small intestine is where the magic of absorption happens, and the large intestine handles water absorption and waste elimination. The accessory organs, liver, gallbladder, and pancreas, are essential supporting players. But most importantly, remember that understanding normal physiology is the foundation for recognizing abnormal pathology. When you truly understand how the digestive system works, you become the nurse who can anticipate problems, provide better patient education, and deliver exceptional care. If this video helped you understand the digestive system better, smash that like button and subscribe for more anatomy and physiology content that actually makes sense. And if you're studying for NCLEX or need more A&P help, check out this video or my playlist about anatomy and physiology. It's the perfect complement to what we just learned. Drop a comment below and let me know what's your biggest challenge with anatomy and physiology. I love helping you guys succeed, and your questions help me create better content. Until next time, keep studying, keep growing, and remember, you've got this. This digestive system might be complex, but you're going to master it. Once again, this is NurseBrain, inspiring greatness one lesson at a time.